دلوقتي مع دكتورة إسراء مطراوي. مش عارفة ليه كاتبة اسيستنت ليكتشر، ده احنا فريش ام دي يعني. هتقدم لنا كيس تانية، مش هنحرقها، هنستنى ما نسمع. اتفضلي دكتورة إسراء.
Okay. First, I'd like to thank my dear professors for giving me this precious chance to present this case. Our case is about a double-edged sword. Female patient delivered on 38 weeks of gestation, first order of birth, non-consanguineous marriage. The mother was para-2 section with maternal gestational diabetes, and the baby was diagnosed with congenital fetal malformation. Delivered by cesarean section on 38 weeks gestation with smooth resuscitation, no reported complications. After delivery, the patient was diagnosed and admitted to neonatal ICU. The patient was having central cyanosis, pre and post ductal saturation was below 90%, with no difference between the two readings. Vitally, the patient was stable, blood pressure and heart rate was within normal for age. CNS-wise, the patient was free with good activity tone reflexes, with no apnea, convulsions, and transcranial ultrasound was normal. Chest-wise, the patient also was free with bilateral equal air entry, no adventitious sound, and the patient was off respiratory support initially. His abdomen was lax with no organomegaly, and the ultrasound was normal. And cardiac-wise, the patient was having audible systolic murmur, mainly left parasternal. During admission, the patient was initially off respiratory support, and then prostaglandin E1 or Prostan was added on day 2 of life on dose of 0.05 mic per kg per minute, and gradually increased to 0.1 mic per kg per minute. Then echocardiography was done and revealed DTGA with large VSD, large elongated BDA for cardiac multi-slice CT, which revealed complex congenital heart disease with ASD, VSD, PS, and small pulmonary artery branches with left-sided aortic arch. The patient underwent a trial for BDA stenting, and unfortunately the first trial failed. During admission, there was a trial to decrease Prostan dose several times and failed, so the patient is considered Prostan dependent. Cardiothoracic consultation at that time, the patient was inoperable. Then, unexpectedly, the patient started to develop diarrhea and tender bony prominence. Joint examination, the patient was having tenderness in 4 limbs with no redness or hotness. The patient was in pain whenever the patient is examined, or during care, the patient was in severe pain. So now we have a patient with complex congenital cyanotic heart disease, Prostan dependent with tender bones. What's your provisional diagnosis? Thinking about septic arthritis, developmental dysplasia of hip, fracture, cellulitis, abscess, Caffey's disease, which is osteosclerotic dysplasia affecting mainly mandible and clavicle, and this is not matching our case, as our case is affecting mainly long bones of both upper and lower limbs, hypertrophic osteoarthropathy, leukemia, metastatic, and metabolic. All of these included in differential diagnosis. Our investigation, CRB and ESR, were done and were negative. Joint ultrasound was free, and skeletal survey was done to exclude any abnormality. This was the skeletal survey for this patient. We can here see the periosteal elevation, affecting mainly the diaphysis and escaping the epiphysis. And we found out that prolonged prostaglandin infusion, this was a case report published in 2017 about prolonged prostaglandin infusion may cause cortical hyperostosis in an infant with cyanotic congenital heart disease. Another case, and they concluded from this case that bone cortical proliferation and clinical periostitis associated with short and long-term use of prostaglandins have been reported as an early within 9 days of initiation of treatment in newborn, and have shown to completely resolve following cessation of treatment. And this is the X-ray for their case. Again, there is periosteal elevation affecting mainly the diaphysis and skipping the epiphysis. Side effects of prostaglandin. As a common complication of prostaglandin for short-term usage, apnea, as we all know, apnea, hypertension, fever, flushing, rash, and diarrhea, necrotizing enterocolitis, gastric outlet obstruction, and bradycardia, while prolonged use cause reversible, which is very important that this side effect is reversible cortical hyperostosis affecting mainly long bones and soft tissue swelling. So, prostaglandin-induced cortical hyperostosis appear to be linked to duration mainly. This according to the case report published in 2017. The percent of patients developing hyperostosis increased from 42 at less than 30 days to 100% at more than 60 days of continuous prostaglandin infusion. The long bones of upper and lower extremities are the most commonly affected, and periosteal elevation of the diaphysis without any destructive changes and sparing of the metaphysis are classical for radiological finding. So, newborn, why newborn with congenital cyanotic heart disease have more risk for this complication or side effect? Because they have diminished pulmonary blood flow, and lung is considered one of the main organs that prostaglandin is cleared through. And so, furthermore, the patients having reduced clearance through reduced pulmonary blood flow with higher doses, higher pharmacological doses given, this will lead to greater prostaglandin concentration in circulation and may lead to osseous complication. So, what's next? The clue for this side effects to stop the drug. But unfortunately, stoppage of prostin in this case was not an option at this time. Especially, the catheter failed. So, management needed strong analgesic and anti-inflammatory. But we mentioned that the patients having BDA, which is a very precious BDA, what about BDA? Can I give analgesic and close the BDA? So, here comes our hero, Presidex or dexmedetomidine. It's an alpha-2 adrenergic receptor agonist. It had a promising efficiency as an analgesic and sedation without respiratory support. Dosage from 0.1 to 2 mic per kg per hour. It has shown to be safe, effective as fentanyl in preterm neonates. Studies showed that it's the ideal option as neuroprotection with no developmental sequelae. It has reduced the need for usage of benzodiazepine and opioid. So my take-home message is prostaglandin are commonly used in neonates with congenital cyanotic heart disease to keep the ductus arteriosus patent, but the definite treatment for this condition is definitely surgery. Awareness of late complications of prolonged prostaglandin therapy is essential. Hyperostosis is a common reversible side effect of prolonged prostaglandin therapy if it's continued more than 3 weeks, although it can present as early as 9 days after initiation of therapy. Isolated increase in serum alkaline phosphatase level might be helpful in making diagnosis of cortical hyperostosis and can be used as a marker for monitoring the activity of periostites. Presidex or dexmedetomidine has shown promising efficacy as analgesic and sedation with neuroprotection without respiratory depression. And thank you.
شكرا جزيلا دكتور اسراء على البرزنتيشن الجميله. الحقيقه احنا دايما متعودين في الدمرداش لما بيجي لنا كيس غريبه او بنشوفها اول مره بنلاقي منها كذا حاجه بعد كده. يعني البيبي ده كان في محضن الاطفال، احنا بعدها على طول يمكن دكتوره شاديه حضرت معانا القصه دي، كان عندنا بيبي زيه في النساء وطبعا خلاص كنا عارفينه بقى، يعني ما كناش بندور. والحقيقه انها فعلا كانت حاجه فيري انترستنج بالنسبه لنا، كانت من الحاجات الرير اللي فعلا تو بي بوت ان مايند واحنا بندي للعيان البروست. دكتور هاني
انا عايزه اقول بس افضل حاجات في الحاله اساسا دي تي جي اي ومعاها بالمونري ستينوزس. دي تي جي اي هي محلوله عندي لان في اي اس دي وفي اس دي، فربنا حللها مؤقتا بالنسبه لي، فما عندوش مشكله في الوقت الحالي، لكن مشكلته في البالمونري ستينوزيس. لازم لما الاقي بالمونري ستينوزيس لازم اركز فيه. لو اتريزيا ده يبقى urgent، لازم اتصرف لان ده داكتس ديبندنت ولازم احل له مشكلته. لو سيفير ستينوزيس، وده الغالب البيبي ده يا هيكون سيفير ستينوزيس او اتريزيا، فده داكتس ديبندنت، يعني معتمد على الداكت. اذا انا لازم اجري بسرعه، هي دي الحاجه اللي تشغلني احلها، ان انا اجري اشوف حل للداكت. هبعته للكارديولوجي، الكارديولوجي هيشوف الداكت دي لها شيبس، لها 4 شيبس، ممكن تبقى تورشس، ممكن تبقى تيوبولر. احسن نوع لتركيب الستنت هو تيوبولر، ممكن تبقى كون شيبد او كون معكوس، فعلى حسب ما هو بيشوف الشيب بتاع البي دي اي اللي موجود هينفع يتركب فيها ولا لا. اصعبهم ان هي تكون تورشس، احسنهم ان هي تكون تيوبولر يقدر يحشر فيها الستنت. فهو على حسب ما بيلاقي البيبي. حصل فيلير في كذا مرة، إذا دي بقت صعب إن هو الستنت صعب تركيبها. الحل البديل إيه؟ إن أنا هبعته على الكارديو سيرجري. هيعمل إيه؟ هيعمل بي تي شنط اللي هي بلالوك تاوسنج شنط، اسمها بلالوك اسم الراجل، وتاوسج دي مرات اللي معاه، تاوسج مش تاوسنج. الشنط دي بتبقى بين الليفت سبكليفيان وبتبقى واحد من البرانشز بتاعت البالمونري، يا رايت يا ليفت على حسب المقاسات. وعشان كده لازم التقرير يبقى مكتوب فيه للجراح مقاسات البالمونريز. واخلي بالي ان العيان ده عنده بالمونري ستينوزيس سيفير، فهتبقى القاعده ان الشامبر اللي ما بيمشيش فيها فلو كتير بتصغر، فهو ده اصلا عنده يا سيفير بالمونري ستينوزيس يا اما بالمونري اتريزيا. انت ما ذكرتلناش اي جريدينت ولا اي حاجه، بس هو غالبا كده، فهتبقى البرانشات هتبقى صغيره. فغالبا الجراح طبعا هو عنده الشنط اللي هيركبها دي مقاسات، وعنده الليفت سبكليفيان كويس. ما ينفعش لو برانش من البالمونريز صغيرين مش هينفع يركب في الوقت الحالي الشنط، فانا ابقى عارفه عذره ايه، ان هو ماشي حسب مقاسات. فبيقول لنا ساعتها طب استنوا شويه لما البيبي يكبر ونركب له الشنط. فهي دي غالبا مشكله هذا البيبي، ان الستنت ما نفعتش لان الشيب مش مناسب، وبعدين الجراح ما قدرش يتدخل لان مقاسات البالمونريز هنا هتبقى صغيره، فمضطر يستنى. وده اللي خلاكم تدوا بروسن لفتره طويله لان ظهرنا للحيط. فنبقى عارفين بس الناس بتفكر في ايه في الاقسام الثانيه وبيشتغلوا ازاي. شكرا.
شكرا دكتور اسراء. ودلوقتي هنسمع دكتور محمد سيد. الحقيقه محمد من الناس اللي بتشتغل باخلاص ودايما ملتزم في مواعيده، بيحب يعلم. متوقع ان يكون ان شاء الله الكيس. اتفضل.
شكرا لحضرتك يا استاذ دكتور رانيا الفراش، يعني ده شرف كبير لينا، واحنا